Welcome to Perioperative Echocardiography Case Conference coming to you from Vanderbilt University Medical Center. Today I want to present a case that begins here with a short axis view of a trileaflet aortic valve which opens very well with no evidence of stenosis. This is also an RV inflow-outflow tract view with the tricuspid valve here and the pulmonic valve over here. Remember, with an omniplane of around 50, this side of the image on the left is caudad relative to the right-hand side, which is cephalad. The chamber sitting on the esophagus is the left atrium, separated by the fossa ovalis from the right atrium over here. Putting color on the aortic valve reveals a trace central aortic insufficiency, and in systole there is normal laminar flow consistent with a normally opening aortic valve. In other words, there's no aortic stenosis. The other flow we see here over to the right is normal coronary flow in the left main coronary artery. Moving the color box to the pulmonic valve reveals a small retrograde jet of pulmonic insufficiency, which is trace to mild and of no clinical significance. In the tricuspid valve with color Doppler, we see a small systolic jet on the atrial side of the valve. It's very narrow in its origin, consistent with trace tricuspid regurgitation. We'll have to look at further views to confirm this. The final place in this view of the heart in which to place color is the fossa ovalis, where we're looking for any evidence of shunting between the atria through either an ASD or a PFO. A PFO tunnel would be expected to lie along here between the secundum and primum septa, and there is a hint maybe at times of a little color jet emerging from the septum at this level, though I can't definitively rule it in or out in this view, and we need to look at other views. If it were of clinical importance in this patient to definitively rule out an intraatrial shunt, I would do a bubble study with a Valsalva, which greatly increases the sensitivity for picking up intraatrial communication. But the glaring abnormality in this clip is the turbulent flow over here in the right atrium. This does not appear to be coming from the tricuspid valve, nor does it appear to be coming due to a shunt between the atrium. So for now, the origin of this turbulent flow remains a mystery. Now, this four-chamber view on first glance looks pretty normal. You got the left atrium, left ventricle, right ventricle. We can quibble the right atrium is just a little large with maybe a slight bulge of the intraatrial septum from right to left, suggestive of a little atrial hypertension, right atrial hypertension. And if you pay close attention to the tricuspid annulus here and see how much the tricuspid annulus pulls down towards the septum, the apex in systole, you'll notice it is a little reduced and in fact measures only about 1.6. Which is pretty significant depression. So there is some evidence of RV dysfunction. However, if I told you that this patient's in the operating room for an acute pulmonary embolectomy and endarterectomy of the pulmonary arteries, then you might be surprised at how relatively normal this four-chamber view looks. Because normally in such patients you expect a enlarged RV, dilated RV. So we'll have to find out later in the study what's the explanation for this paradox. Now, when it comes to assessing RV size, the definitive paper or guideline is from 2010, and it defines the upper limits normal of RV dimensions at the annulus as 4.2 centimeters, in the mid RV as 3.5 centimeters, and the free wall thickness of 5 millimeters. Now, it's worth noting that this paper emphasizes the use of an RV-focused view. In other words, you don't use a classic 4-chamber view to make your measurements. You omni down to maximize the RV diameter. This would be the 4-chamber view. View 3, then as you increase the omniplane, you cut through wider and wider parts of the RV and you maximize the RV diameter, and that's where you should measure. Now here's a mid-esophageal ascending aortic view. The main PA is off the picture as it branches into the right PA here. The left PA would be off over to the right here. And the main thing to notice, I hope you can appreciate, is that there's a mass in the right PA. And this is a pulmonary embolism clot due to embolism. And this is the source of this patient's problems. So we have the right patient, just the 4-chamber view didn't quite match with what we thought the physiology would be. But the answer to the conundrum is in the SVC here. There's something in the SVC. This is SVC adjacent to the ascending aorta, and further over there's another short axis structure, and that's the right upper pulmonary vein. But in the SVC there's this bright echogenic structure, and this is a cannula. You just see it as the bright reflections from the anterior and posterior walls of what's actually a circular cannular structure. We don't see the two walls on either side because they're parallel to the beam of ultrasound. So it's actually a circular structure, just appears as two distinct shadows. So the mystery is solved when we throw a cut vertically through that cannula and we see turbulent flow in the right atrium entering a cannula which is going up to the right IJ and out to an ECMO machine. So the reason this acute pulmonary embolism patient doesn't have a dilated RV is that they're on VVA ECMO. And this is what explains that view that we saw earlier with a turbulent flow in the right atrium. So that concludes this episode of our ECHO case conference. I hope you found it of value. Please address comments and questions to the Twitter account shown here. Thank you very much.